Hi, everybody. I'm Jackie Cohen-Roth, founder, CEO of Cannabis MD. I'm really delighted to have you join us today for neurologic disorders, medical cannabis, clinical applications, and research. We are scheduled for an hour, 3 to 4. Each one of our panelists has graciously agreed to stay with us for an extra half hour so we can get through what I'm sure to be a lot of questions. Over the last several weeks, I've had the honor and privilege of building today's program with our panelists, who are three leading cannabis scientists and researchers that you're about to meet. First, I'd like to go through some housekeeping details with you. The chat's not open so that our collective focus will be on the discussion that we're about to have. As I said, we do have a Q&A period that'll follow, and that'll be between 30 and possibly 40 minutes. I am grateful to have several of my Masters of Science and classmates at the University of Maryland School of Pharmacy join us today. And when you enter in your questions into the Q&A, if you would please preface your questions with MCST so that we can prioritize your questions. I have a very special thank you to one of our classmates, Brad Paleg, who's supporting us with some Zoom tech, as well as my Cannabis MD colleague, Sharmila Klee. And we are, again, focused on making this a really great experience for us all. I want to give a thanks to our sponsors. That if you give me a moment, I'm going to be sharing my screen, and okay. Our first sponsor that I'd like to give a shout out to is Vireo Health. Vireo Health, I've had a pleasure to know for a couple of years now. They're a physician-founded, patient-focused company that's dedicated to providing best-in-class cannabis products and unrivaled care. Vireo integrates fundamental medical, scientific, and engineering practices into the cannabis industry. Vireo is committed to creating safe, all-natural cannabis products and a compassionate patient experience. Vireo operates in multiple states and serves patients at licensed dispensaries and Vireo grain goods locations nationwide. A shout out to another sponsor is Wana Brands. Wana Brands' mission is to help build people enhance their lives physically, creatively, and emotionally through the responsible use of cannabis. Guided by its values, including resiliency, honesty, integrity, respect, and collaboration, Wana Brands is the #1 infused cannabis product company in the country and advances the local and global movements that make cannabis legal and accessible to all. A third sponsor I'm very grateful to have is District Cannabis. District Cannabis is the premier cannabis cultivator in the DC, Maryland, Virginia region, pairing data-driven approach with decades of experience and a true understanding of the plant's medicinal potential. What we're going to be focused on, of course, is medical cannabis. Stop my share, which is now legal in 36 states, and the demand for market growth is rather incredible across the country, across the world, particularly in Europe and Latin America. With an overwhelming number of Americans saying that cannabis should be available in some form, whether it's adult use, or medical, or both, it's very likely that more states are going to be launching a program, some sort of program, in 2021. As adult use markets launch, a medical program of some sort will be staying intact. Now, each state has its own list of medical or qualifying conditions for medical cannabis. And that means that patients need to be treated with medical cannabis, again, with a varying of medical conditions, but at least one neurologic condition is on each state's list. These disorders include Alzheimer's or AD, Parkinson's disease, PD, and seizures disorders, epilepsy being the most common. Of note, children who present on the autism spectrum disorder or with an autism spectrum disorder known as ASD have an increased risk of epilepsy. Currently, unfortunately, there are no cures for any of these disorders. Pharmaceuticals can reduce the severity of the symptoms that are associated with each one of these disorders, but the associated side effects of the pharmaceutical medicines can be perhaps even more severe than the symptoms itself. Medical cannabis has been shown to be effective in treating symptoms associated with these disorders and with far less unpleasant side effects. And now I'm delighted to bring on board our three panelists. If you would join us, that Dr. Patricia Fry, Dr. Ethan Russo, and Dr. Bonnie Goldstein. Welcome.
Thank you.
Thank you. Well, I'm going to go clockwise as you present on my screen and have each one of you take a couple of minutes to introduce yourself. I know most of the attendees are quite familiar with your focus as a cannabis clinician and scientist. So, Dr. Goldstein, if you'd please introduce yourself.
So my name is Bonnie Goldstein. I am a physician here in Los Angeles. I trained as a pediatrician and then went into the practice of pediatric emergency medicine. For about 13 years, I did that. And then I took a little time off, but then I heard from a friend of mine who was actually quite ill that she was thinking about using medical cannabis. And she asked me some questions, which I couldn't answer. So I went on a journey of discovery, and now I've been in this with my practice now almost 14 years. I've seen thousands of patients, and right now I'm focusing on taking care of children with chronic illnesses, including epilepsy, autism, cancer, and so on. And I just recently published my second book called Cannabis is Medicine, trying to share that experience with all the research and the science that we have so far, which actually is quite a bit, and plus the multitude of anecdotal stories and millions of people that we should not be ignoring.
Thank you. Dr. Fry, welcome.
Well, thank you, Jackie. Thanks for inviting me. I'm Patricia Fry. I am practicing medicine, a more integrative practice in the Washington, D.C. area. I'm actually boarded in pediatrics like Dr. Goldstein. I practiced in Southern California for most of my career, where I did a lot of evaluations behavior and school problems in children. I did most of the children in Orange County, California, who are with Kaiser Permanente. I sort of stumbled into cannabis after somewhat being retired, but I also trained in anesthesiology after pediatrics, and so I gained a lot of experience there in sedation, of course, but in chronic pain management and pain management procedures. And so cannabis kind of came upon me as a job, as a telemedicine job I was looking for when I was somewhat retired and had returned back to the East Coast. And after evaluating, a large number of patients at the end of the year, I was fairly impressed with this plant and the benefits that it brought so many patients. And so I sort of came back out of retirement and opened this integrative practice where I incorporate cannabis and lifestyle and nutritional changes to help people get better and feel better. And I'm also on the faculty of the University of Maryland School of Pharmacy as an adjunct associate professor in the program of medical cannabis and science and therapeutics. And my book, which is the Medical Marijuana Guide, Cannabis in Your Health, is one of the resources for the program. So thank you for being here, and thank you for inviting me.
Thank you. Dr. Russo.
Yes. Hello, everyone. I'm Ethan Russo. I'm a board-certified child and adult neurologist. I was in practice in Missoula, Montana for 20 years until 2003. But along the way, I got involved in the cannabis controversy. And in 1998, the year that GW Pharmaceuticals began its pursuit of pharmaceutical forms of cannabis, I was asked to come on as a scientific advisor. And then in 2003, I was asked to come on in a full-time position, a senior medical advisor. And I was involved in about 25 phase 1 to 3 clinical trials of Sativex and Epidiolex, the only two pharmaceuticals derived from cannabis that are approved in various nations in the world at this time. So I've currently been in cannabis research and development for 25 years now that it's 2021. My current position is CEO and founder of Credo Science, which is a company dedicated to developing intellectual property related to cannabis and the endocannabinoid system, as well as providing formulation and other consultation services.
Thank you. Welcome. And yeah, I know your respective studies and books are well dog-eared as I've been going through. And prior to being in the MCST program at the School of Pharmacy, self-taught, and then it's quite an honor to be in this groundbreaking program. So moving on and starting our program. So there's some basic terminology that most of the folks that have joined us are familiar with. We're going to be talking about the endocannabinoid system, or the ECS. We're going to be using chemovar versus strain. And then, of course, we're going to be talking about terpenes, the essential oils of the cannabis plant. So starting off, we're going to be going into just some general information related to cannabis science and neurologic disorders. So Dr. Goldstein, kicking it off with you. So what is the connection with the ECS specific to neurologic disorders?
Well, so what we know is that the endocannabinoid system is the largest receptors, most widely spread receptor system in the brain. And it has a major role in the regulation and function of neurotransmitter release and impact. And when we look at a lot of the neurologic disorders, we understand, so for instance, I know we're going to be talking about Parkinson's. So for instance, the area where Parkinson's, the area of the brain where Parkinson's is, where the problems are, we know that cannabinoid receptors, as well as other receptors that now are linked to the cannabinoid system, such as the TRPV1 receptor and some other receptors, are densely located in the area where Parkinson's stems from. So we can't ignore the fact that the endocannabinoid system exists, which unfortunately current conventional treatment really doesn't look at using the endocannabinoid system as a target of medication and control. And this is why cannabis medicine is so important, because we can't ignore the endocannabinoid system either as part of the reason maybe there's dysfunction within the system that is actually one of the causal roots of the condition, or as a target of treatment. And that's very important to understand, is that if there's pathophysiology within the system to begin with, can we balance that and either improve the symptomatology or even stem the continuation or progression of disease. So it's very important that we cannot ignore that the endocannabinoid system first exists, but two, plays a very large role in many of these conditions that, as you mentioned, we don't have cures, and that we don't have a real understanding of best treatment at this point.
Yeah, thank you. And as we move forward, and we're going to be touching upon, for example, Alzheimer's, and that can cannabis be effective in stopping the progression of disease. So Dr. Fry, I know I've had this conversation with a couple of providers that I've hosted on previous programs where they've disputed the efficacy of terpenes And of course, part of that is the terpenes working with the cannabinoids, and together is what's known as the entourage effect. So if you could just, is it real, the entourage effect, very simply put?
Well, I'm convinced it's real. The entourage effect, as you know, was first described a long time ago by Raphael Mechoulam and I think another researcher, Ben Shabbat, that says that the sum of the components of the plant are of more value than each individual component, and that these terpenes and flavonoids and cannabinoids all work together. And it's very apparent to me in clinical work, and I think Dr. Goldstein would agree that you can have, first of all, you can have a CBD isolate, say, treating a symptom where you need much higher doses than you would if you had CBD in combination with terpenes and flavonoids and other compounds in the plant. And we really just know the tip of the iceberg in this plant and how these other compounds interact or influence how these cannabinoids work. So, and actually how they work with each other, because you can have a child or a patient on a CBD product where you have clinical efficacy, resolution of symptoms, and for whatever reason, either they don't get that same product or it's not available, they try something else, and it could be a matter of the terpene profile is different, particularly some of the relaxing terpenes that we find help the CBD be more efficacious in things like seizures or irritability in autism, or it could even be how these cannabinoids work together. For instance, CBG in combination with CBD has a much higher anti-inflammatory effect. And many of these conditions do have not only a neurotransmitter issue, but oftentimes there are elements of neuroinflammation that are affecting these patients. So I absolutely see how terpene profiles can influence how the plant works, not only for neurological problems like seizures and irritability, but also things like sleep. There's something, what makes one product with CBD or THC or the combination help people sleep, and the other one helps them clean the house. It's not the cannabinoids by themselves. It's what else is in there.
You used the word flavonoid, so we talked about the chemovar terpene, and if you would just educate us on flavonoid.
Well, this will be brief because
yes.
we don't really focus a lot on flavonoids.
Yeah.
It's sort of it's like the frontier part of looking at these chemovars, because we know they're there, but we don't test for them. At least in any market that I'm working in DC, Maryland, Virginia, no one tests for flavonoids, and so we really don't know how they, at least I don't know how they influence the plant. I imagine they have some influence, particularly with things like inflammation or perhaps apoptosis, which would be part of the inflammatory response. But these are other compounds that are found throughout nature that give plants their medicinal, add to their medicinal benefits. There's certainly some that have anti-tumor activity, anti-inflammatory activity, but we're not there yet in terms of knowing how to best use these flavonoids in combination with cannabinoids and terpenes.
All right, thank you. And Dr. Russo, so we've been using some of the terminology, and we'll be using more throughout our conversation, but if you'd help us differentiate between hemp-derived CBD, marijuana-derived CBD, and isolate versus a full plant spectrum.
Sure. Well, hemp and cannabis are from the same species. The current definition of hemp in the USA indicates material from cannabis with 0.3% or less THC content. But that's arbitrary. It might be raised to 1% at a future time because 1% material that people would smoke normally is not going to get them high. So they're very artificial distinctions. Isolates mean single compounds. For example, cannabidiol, CBD, as opposed to a CBD extract that would contain these various other components, perhaps a little bit of THC, some cannabigerol, CBG, and the various terpenoids, as we've heard. And again, there's a developing literature to support the idea that the extracts give better clinical results than the isolates, and there are examples in the literature.
Thank you. All right, so we'll get into our program again, each on a few of these neurologic disorders, and starting off with Parkinson's disease. Dr. Goldstein, if you share with us what you consider the best cannabis preparation for treating Parkinson's disease.
I don't know that there is a best preparation, okay? Because Parkinson's disease is not a static condition. It's something that starts and it changes over time as the person ages. There's changes going on in the brain. And something that may work in the beginning may not work at the end. And so it's very important to understand that for most cannabis clinicians, we do not take a condition and then say, oh, I use this for that condition, because it really depends on the individual. Cannabis is not cookie cutter. It's not one size fits all. Now, I might start certain patients on, let's say, for instance, in patients that have Parkinson's, you know, when you look at the research that exists, and there's something like, 8 or 9 clinical trials, but of course, they're not all using the same products. Some of them only have 7 patients, some are surveys. You kind of have to look at the overall from the research. And it appears that both high dose CBD may be something that can help certain patients. I've had success with that in some patients. There's some evidence now that THCV, so tetrahydrocannabivarin, may be helpful for these patients. And again, both CBD and THC do not have impairing or intoxicating effects. So these are nice options for patients. But I've had a few patients with Parkinson's who find daily, like microdosing or low dose THC takes the edge off everything and allows them to function better. I think it's really important to understand that taking a history from a patient and customizing and personalizing the treatment for these patients is very important. It's not the same as what we do in kind of conventional medicine. If you have a certain kind of condition, these are the medicines. It's very different. And again, remember, we have very complex neurochemistry, and the plant is complex with hundreds and hundreds of compounds, and we're trying to find a match. Mm-hmm. And I've had 2 patients, let's say, with the same condition on paper who get a completely different response from medications. I think customizing and personalizing is very important. That being said, one of the things about CBD that I think is just very important to note here is that many products that are available when people are looking at products, whether they are online or whether they are through a state-sanctioned dispensary, when you purchase a bottle of CBD, if you, let's say, were to say, like, I only have $80 to spend, that may not buy you very much CBD oil or, milligrams of CBD. And what we're understanding more and more now is that it looks like higher doses of CBD are required for some of these more serious conditions like Parkinson's, like epilepsy. Some kids with autism may respond very low dose, but many of them need very high doses. And it can become a little cost prohibitive, I know, for some patients, but I will just share with you that I see a lot of people that come in and say, oh, we tried CBD, it didn't work. Mm-hmm. And then the question is, well, how much did you take? What's the quality of the, and if you buy a bottle of 100 milligrams of CBD in a bottle and your daily dose is 300 milligrams, that's just not going to cut it. So it's very important that people understand dosing matters. Mm-hmm. Now, for someone who wants to take a puff off a vaporizer just to take the edge off some anxiety, go to sleep, dosing there doesn't matter very much. You're just, you can it's well known that people who inhale can regulate that. But at the same time, when you're talking about CBD, as maybe even a daily medication dosing really matters.
Mm-hmm. Yeah, and so I mean, you talked about there's some certainly variabilities here. You've got the lack of standardization between products within a state itself. What you're going to get with a cultivar is going to change, and then as well as the individual's ECS, that also is changing. There's variability there. Dr. Russo, are there any particular, I'd say, symptoms of Parkinson's that are more beneficially impacted by cannabis?
Right. Well, I really couldn't agree more with what Bonnie said. It really depends on the individual and what the target symptom is. So Parkinson's disease, so-called, is a constellation of symptoms that include rigidity, tremor. Tremor is a very difficult thing to treat. Additionally, bradykinesia, slow movement, but it's also associated, particularly in its later stages, with the development of psychosis and dementia. Agitation, sundowning, the tendency to get disoriented at night. So any of these things might require THC in a given instance or CBD in a given instance, or even cannabigerol for its anti-anxiety effects. I'd also like to mention one study. I'm not usually very excited about surveys, but back in 2004, Vendorova in the Czech Republic described a series of patients. There was a fellow there who had eaten raw cannabis, and he was on their equivalent of 60 Minutes, a news magazine television show. And so this became widely publicized, and they had a large series of patients who similarly were eating raw cannabis in some form. And what was noted was very interesting. The entire constellation of symptoms and signs of Parkinson's seemed to improve, but with a definite clinical lag. People didn't necessarily get their full benefit until 3 months out, which is so different from what we usually see, where cannabis normally exerts changes very rapidly. So it raises two questions. One is, could it be THCA, tetrahydrocannabinolic acid, that is going to be better for some of these people? And that could be due to any number of reasons, particularly its effect on a nuclear receptor called PPAR gamma, or its effect on tumor necrosis factor alpha, both of which are established mechanisms. So that's one issue. And the second is, why the lag? Is there some subtle change going on in the brain and the neurotransmitters that takes a long time, in contradistinction to the immediate effect we usually associate with cannabis-based medicines?
Yeah, and THCA, as you said, so they're eating the plant, that's not available in most medical states. That patients do not have that opportunity to have plants at home or to go purchase, like I've said, a bag of arugula to be able to buy some leaves. I'm curious, so what kind of quantity was that measured of?
No, it wasn't. It wasn't a quantitative study.
Yeah.
We would tend to think that THCA is going to be more potent. And so, in this instance, I wish I could say what the dosing was, but presumably the dosing's a great deal lower than would be necessary for cannabidiol isolate, for example, because their effective doses in these difficult disorders might be hundreds of milligrams, as Bonnie mentioned. Here, I think we're talking about tens of milligrams at a time, but I would emphasize that's not clearly established. And because THCA, before it's decarboxylated, is not intoxicating, it would be hard for someone to titrate their dose to the effect, particularly if the effect is delayed. And I'd also point out that usually when people think about eating cannabis, they're talking about eating leaves or juicing leaves. The leaves are a poor source of the cannabinoids as compared to the flowers. And so if someone were interested in this, what they should be doing is tincturing or doing an oil extraction of the flowers. And that's apt to be quite potent, and it may be that very low doses of that are going to be necessary. But underline 3 times, we don't know yet how much might be effective.
Yeah, and unfortunately, I think that's going to be an answer throughout the conversations. We don't know yet because of the restrictions on clinical trials. Dr. Would you speak to your recommendations as far as dosing and actually as well add delivery methods for a PD patient?
Was that me? Because you
Yes,
broke up.
thank
Okay.
you. Yep.
And just not to get too far away from the acids, is that I commonly recommend that patients buy flour, either when it's available, 1-to-1 chemobars that have CBDA and THCA, and either making tea with them, because using the hot water for that brief period of time isn't really going to decarboxylate very much, or adding bits of buds to their green smoothies so that they're getting those acids, and that because as Ethan said, the bioavailability is so much better, you don't need as much usually to get some effect. I have found for my, and I don't see a lot of Parkinson's, so I'll preface that I see more pediatric issues like with autism, but I have found that THC has been very helpful for the tremor, which is difficult to treat, and that generally inhalation would be the way I would advise patients to use cannabis. It's actually rather nice because even though it's impairing, if you're using inhalation, the effects aren't going to last that long, maybe a couple of hours. And these patients can either vape or smoke and get that a tremor under control. And the male patients like it because they're able to shave, without, shaking or eat, get dressed, button, do those sorts of things. But I really don't see that many Parkinson's patients. But anything in cannabis is you always start with a small amount. There is no real dosing. Everyone has a very unique endocannabinoid system. There are a lot of polymorphisms on these receptors. What works for patient A may be way too much or not enough for patient B. Everyone has to start with a low dose. I always tell patients, don't pay too much attention to the instructions on the box when they say like take a dropper full or this or that. You always start with a small amount and gradually increase. With neurological issues, I generally have them titrate at a much slower rate than I would for something, let's say like pain. So I might have a patient start really with a microdose of 2.5, 3, 4 milligrams of these cannabinoids, and stay with that dose 2 to 3 times a day for 10, 14 days before increasing it. I think we all have a little bit of different style as to how we instruct patients to titrate based on our experience. But the bottom line is there really is no real dosing, except you have to remember that the cannabis is biphasic. Most of these cannabinoids, if you give too much, it's the same as not giving enough. And you can actually exacerbate symptoms if you give way too much. So in order to know what's enough, you have to start really at a very low dose and gradually increase. When patients start with larger doses and it's not working, I always tell them, well, I don't know which way to go. I don't know if you're taking too much or you're not taking enough. So I see patients who respond to very small doses, and people might say that that's placebo, but if it's working, it's working. And then others, they need much larger doses. So it always ends up being start low, go slow.
Thank you. We'll move on to Alzheimer's disease. Dr. Russo, you and I had the opportunity during your video profile to talk about Alzheimer's disease. And so question back to you is, what is the prospect for actual neuroprotection by cannabis in Alzheimer's disease?
Well, I think it's promising, especially since there's nothing that conventional medicine has provided that's been any good at all. There are two issues in Alzheimer's disease. One is symptomatic treatment, so dealing with the agitation, trying to deal with the memory loss, trying to get people to sleep, all those aspects. And there's no doubt that cannabis may be the preeminent medicine for treating those constellations of symptoms. But the real issue is, can we slow down or arrest the progression of the disease? And the answer is, theoretically, there's a strong basis for thinking so. There's been a lot of work dating to 1998 showing the neuroprotective effects of both THC and CBD. But more specifically, there's been subsequent work with both THC and CBD showing that this interferes with the buildup of the abnormal proteins that are part of the pathological process of Alzheimer's disease. So amyloid, tau proteins, neurofibrillary tangles, all this that's part of the pathology may be subject to treatment with these. We don't have a body of experience yet that we can point to indicate that absolutely this will work. But for example, our colleague Jeff Hergenrather in California, he, among other things, works at a nursing home that has a large number of demented patients with Alzheimer's disease, and they've had fantastic results treating patients symptomatically. And apparently there's another nursing home in town where they don't allow cannabis, and the children of the patients at the other facility are trying to get them transferred to the one where they do use cannabis because they're doing so much better. So it's sort of an N of one trial on the nursing home level.
I've been curious as with the plaque buildup that's associated with Alzheimer's. And does the body, is that an inflammation? And that would then, I go to think like, okay, is that where CBD comes in and decreasing that inflation? And that.
Yeah, we're not talking about one mechanism with any of these. So yeah,
Yeah.
there are many reasons that CBD may benefit with its myriad anti-inflammatory effects, as well as a direct effect to help prevent this abnormal protein buildup. Again, this is a complex disorder. Normally speaking, to treat Alzheimer's disease, you'd be talking about a cocktail of different single drugs, whereas a properly constituted cannabis extract with different components could really address each of these different issues for a specific patient. So to help with sleep, to help with agitation, to help prevent hallucinations, and again, offering the prospect at least of neuroprotection.
Dr. Goldstein, do you have any Alzheimer's patients in your practice that you can speak to and your success with treatment and what you're doing with them?
Yeah, so before I kind of focused on children exclusively a few years ago, I had a handful of patients with Alzheimer's and other dementias that I have treated. And there's no question that for symptoms, that going through and I always tell everybody, there's a method to the madness. Now there's so many products on the market that the average person walking into a dispensary may be overwhelmed by what they see and not know what THCA is and not know what these other compounds are. So kind of the method to my madness is to try to pick out which symptoms are bothering them most, try to target those, and then kind of slowly go down the line and try to help with each symptom using the various cannabinoids to treat. And so, one particular patient, I even wrote about her in my book. Her husband gave me permission. This is a woman who just kept getting worse and worse on the cocktail of pharmaceuticals that Ethan talked about. And she ended up being hospitalized in order to make some rapid medication changes. Because remember, these medications, you can't just pull somebody off of them. For the most part, they have to be weaned or slowly transitioned. And this particular patient was in terrible, in fact, it's one of the few patients I did a house call for because she couldn't even come into my office. I tried high dose CBD to start off with. This is a person who had full-time 24-hour care, was unable to do any activities of daily living, had stopped speaking. In fact, was basically just either agitated or catatonic. Those were the two states. And when I started CBD, low doses, medium doses, and high doses actually agitated her. So we ruled out, high ratio CBD, and I switched her over to THCA. And, Ethan was talking about we don't really know dosing and so on, and that's true. But again, following the model of start low and go slow, we basically now she's on 15 milligrams of THCA 3 times a day with as needed THC for agitation. And it's been remarkable. She now recognizes family. She's now assisting the nurse with activities of daily living. She's sitting at the table with the family eating. One thing is she's not regained the ability to have a conversation, but her husband said she used to love to sing and she started singing again.
Wow.
So she went from 5 medications down to 2. So between cannabis and these 2 medications, she's been able to remain at home, which is very important for many families, that patients don't have to be, put into a home somewhere. But she also, I have to say, she's had continued benefits, as I've described, now going on, I think 3 or 4, we may even be at 5 years. I'd have to look at the chart, but very important to understand that this ability to sustain benefits over time has really been remarkable. And again, I always just caution, this doesn't mean everybody with Alzheimer's is going to respond. But based on what we know so far, and based on the fact that cannabis is very well tolerated and extremely safe, even if you take too much, it will wear off and there will be no irreversible damage. It is certainly worth a try, especially in these conditions where we don't have a lot of other options.
Yeah, I mean, that's powerful. I unfortunately lost my dad to Alzheimer's. And so to see the trajectory of the disease and his decline, and, you're talking about the number of medications, and I'm thinking about polypharmacy. And, once she was removed from those traditional drugs, could they have been the source? I mean, certainly there's that balance of treating with the cannabis and also the consideration of the other treatment methods that she was on, that I spoke about at the very beginning of, that the side effects could be worse than the disease.
Well, I agree with that. And certainly removing those medications may have contributed to the benefits that we are seeing. It's very hard to tease out between what the cannabis is assisting with or what removal of medication. But I think one of the more interesting things a part of this is that she has now not progressed she has not gotten worse, which I find fascinating, because really when I met her, she was 4 years in and she was on, no question, a downhill trajectory. And so the fact that she has been now kind of even or even better, and it is sustained, is very fascinating to me.
Yeah. Which leads to a question, Dr. Fry, is, we're talking about the traditional pharmaceutical products and with cannabis and the possible drug-drug interactions. So if you could shed some light and discuss considerations for that.
Okay, well, there is probably more theoretical risk than there is what we actually see, at least at the doses that we typically use. As you increase the doses, you may increase the likelihood of running into drug-to-drug interaction. This is mostly with consumed cannabis that has absorbed through the intestines, has to go through the liver. We don't see this much with inhalation, which bypasses that. But the main culprit is the cytochrome P450 3A4, which is found in which is needed to metabolize about 65% of the pharmaceuticals that we write prescriptions for. And so if you think of it somewhat like grapefruit, if you're using a medication that needs that enzyme to be metabolized, if you don't have that enzyme available, you can have higher plasma levels of that medication than you would expect. And CBD tends to be the hogger upper of that particular enzyme. So when you have a medication, it can do one of two things. It can either cause an increased level of a particular medication, higher than what would be expected, where you can get into toxicity. So it can narrow the therapeutic window of that medication. Or if that medication is not metabolized, in some medications, it's not the medication that is active, but it's the metabolite. So you could actually decrease the efficacy of some medications.
Mm-hmm.
And generally speaking, I have there are some medications that are more of concern than others. There's some anticonvulsants like Depakote that we tend to see higher levels of valproic acid in patients when they're using especially high doses of CBD. We don't see irreversible liver damage, but still we don't like seeing liver enzymes go up. So we're a little bit careful with that and monitor those levels to make sure that we're not getting into toxicity. Another anticonvulsant, which is actually a benzodiazepine, is the trade name is Onfi, and it's you can tend to see higher levels of that with increased sedation when you're using CBD in close proximity. That's another one. We're careful with things like blood thinners, like warfarin. We don't want those the coagulability of the blood to be so high that patients are at risk of a bleed. Some other medications that I pay a little bit more attention to are things like beta blockers. So if I have a patient who's on a beta blocker for an arrhythmia, for high blood pressure, because those can lower the heart rate, I'm a little bit careful with those. So these medications don't stop me from using CBD. There's some that that I would space several hours apart from CBD, or follow drug levels if it were something that was that was more concerning, like warfarin or valproic acid. But generally, you have to think about it. That look at the like how many people are going into Walgreens and grabbing CBD off the shelf, and they don't know that the CBD could be problematic, and we don't see people falling over from drug toxicity. But yeah, they're I deal with it, and most of us, I think, that use cannabis in especially specialized practices are dealing with vulnerable patient populations who are on a lot of medications, who have a lot of medical issues, and so we are careful. A low dose, microdosing, I don't think there's much of an issue, or at least I don't see it clinically. When you get up into some higher doses, then depending on the medication, I have those patients space the CBD apart, 2 to 3 hours apart from their other medication. And it may be overkill, but I just would rather overreact to it than be responsible for someone having a problem. There's some other enzymes that are involved with CBD and THC, and probably with some of the other cannabinoids. But it's that 3A4 that tends to be a little more problematic. Or if it's a medication that utilizes all of those enzymes, like 2C19 or 2C9 and THC. If it's a medication that needs all those enzymes, then you need to pay attention and kind of space them apart.
So there's a question for everybody then. So with a patient, like an Alzheimer's patient and a Parkinson's patient, are they more likely to be older? And so are you then more likely to stay away from edibles, that then you're recommending that vaping, inhalation that you spoke of, rather than and add a tincture, consideration of a tincture versus?
I'm more of a tincture person. And I that's not to say that edibles don't have their place. For neurological problems, I'm not so sure that they're that advantageous. They can be very advantageous for pain patients because the THC, the delta 9, is converted to an 11-hydroxy. While it's more impairing, it also has it seems to have better pain relieving benefits. But it is it's not something that I go to. Edibles, true edibles, like where you have to chew it up and swallow it. It's because the absorption is so unpredictable. The onset of action is so unpredictable. I like tinctures because they're a little bit faster acting than a true edible, with some oral mucosal absorption. Then you swallow some, and that kind of extends the length of time that it's active. If nasal were available, I probably would be a big fan of nasal sprays. They have quick onset, like inhalation, but none of the adverse effects on the cilia and the airways that smoking and vaping has. So I generally start patients with tinctures because it's a little bit easier to control the dose, or with inhalation if it's something where we need higher levels, let's say of THC, let's say a Parkinson's patient with tremor. But I'm not against any mode of delivery. Whatever works best for the patient is generally what we go with.
Thank you. Okay, and we'll move on now to the autism spectrum disorder. And Dr. Russo, with you, we're going to be talking about Epidiolex in a bit, but just at the very beginning is why is cannabis so efficacious to treat children with autism?
Well, first of all, let's define things. Autism spectrum disorder is not one disease. It is a syndrome. There are many different causes. It's associated with many different problems. Some are genetic. Some we just don't know. It's clearly not from measles vaccinations. So we're not talking about one disorder, but clearly there's a set of signs and symptoms that we associate with autism and that seem amenable to treatment with cannabis. But as Bonnie can attest, what an individual patient needs is going to vary tremendously in terms of the profile. But it is clear that the endocannabinoid system is involved. There have been some studies to support the idea that there's an endocannabinoid deficiency, anandamide levels too low in patients who are affected with this disorder. So there's a very rational basis for THC to try and make up that deficit. By the same token, we believe that CBD in chronic use boosts endocannabinoid levels by inhibiting the reuptake of anandamide and interfering with its metabolism through the Pha enzyme. But in practice, a tremendous amount of experimentation is often necessary to find the right mix for an individual.
So Dr. Goldstein, you have a lot of experience in treating children ASD. Would you speak to the behaviors that you've seen that cannabis has been so beneficial in treating?
Sure. Usually the trigger that's bringing patients into my practice for autism is what some people describe as the irritability, but really aggression, self-injurious behavior, long, uncontrolled outbursts at all times of the day. I've seen videos at 3 o'clock in the morning of someone having a 2-hour meltdown, which is obviously not going to work on a regular basis for most families. I have families that have hired nannies to stay up at nighttime with their children who don't sleep or who sleep 2 hours. So also for a lot of these kids, a lot of the behaviors, the outbursts, the rigidity, the overwhelming, what a lot of parents describe as anxiety. And remember, a lot of these kids are nonverbal, but some are. Some of the kids are able to communicate through typing or through various devices, and they will describe the overwhelming anxiety that they feel 24/7. So there's no question in my mind in treating these patients, and I talk to so many families on a regular basis, sleep, outbursts, aggression, self-injurious behavior, focus, rigidity, all of those things. And, remember too, there's some patients that are really good responders. It is clear cut. This is working. There's no question. And then there's some patients that are moderate responders. And then some patients that either respond very little or don't respond at all. But when you look at, there have been 4 retrospective surveys published over the last, I think it's 4 years, that looked at patients either using like a 20-to-1 CBD to THC ratio, or using that initially and then adding in THC afterwards. And then in one study, they talked patients were using a variety of high THC dominant, CBD dominant, or a 1-to-1. And all of them describe somewhere between 60 to 90% of patients responding with either significant improvement or moderate improvement. And I will share with you that for these families, there's very little else on that's available. Dr. Fry gives a lecture that I heard a number of years ago, where she went through all the other drugs that patients can be offered. So there's only 2 FDA approved drugs in the United States. Both are antipsychotics. And they don't address the core symptoms. They only address the irritability. So basically what we're doing is just kind of tranquilizing these kids. And that's certainly not, that may help you get through your day, but it certainly doesn't help your child in the long run. And looking at the drugs that are being used off label, they have, really no evidence. And certainly when you see that these patients, as Ethan described, with likely underlying endocannabinoid deficiency disorder or dysfunction, why not target what we may see as one of the root causes of the condition? So no question in my mind that these symptoms can be helped. And I'll just share a quick anecdote. I did a follow-up the other day with a family, and the mom told me that the child had their IEP, which is like the assessment for school. And as they're going through it, she kept saying, "Are you sure you're talking about my child? That doesn't sound," because it was so good. And this is a child who literally is taking 3 milligrams of THC before he leaves the house in the morning. That's it.
That's it.
And the school has said he's met every goal that they have set for him, his behavior, his focus, everything. Now, she says at home, behaviors are a little more challenging, but at home behavior,
that's home.
with neurotypical kids is challenging. So, but when you see the school who doesn't know, who is giving this feedback to the family, we can say this is not a placebo effect. This is not wishful thinking from the family. These are people involved in the children's day-to-day who are reporting incredible benefits. So, I think we have to really look at, what's the ultimate goal with these kids, and that is to get them up and functioning. And anybody who thinks that we're just getting kids stoned so they can just sit in a chair and not be a trouble to their family or a burden, that is not what we are doing with cannabis. We are getting these kids functioning, sleeping, and just, a better quality of life.
Thank you. Dr. Fry, in your patient population, and I'm curious, is that as these kids age and as the hormones kick in, how do you treat your patient? What are you seeing?
Well, I treat them the same way. And yes, sometimes those hormonal changes do exacerbate pre-existing symptoms like irritability. But I treat them the same. I have cannabis works so well for these, I think, for a lot of these patients, because it has its hands in so many different neurotransmitter and hormonal systems that are affected, or where we find that, for instance, oxytocin, the hugging hormone, which is gives us the good feelings with social interaction, and certainly social interaction is a core morbidity of autism. Well, there's interaction between anandamide and oxytocin, so it would make sense that if you can raise anandamide levels, that you may get a more typical response to oxytocin secretion if you need that extra anandamide. Another big component of autism is neuroinflammation, and cannabis is an anti-inflammatory. So there's no difference, at least I don't see a difference in treating a kid who's near puberty versus a younger child. The symptoms are the same. The problem is bigger because the patient's bigger and heavier. And so when they do lash out, when they are aggressive, it can be more problematic than a little, 50-pounder. But I go through, I generally start with CBD. It's very accessible. I've found that CBD with CBDA can be very effective for these patients. I also use CBD in combination with CBG. The science says that it's a better anti-inflammatory than either one by themselves. I also use nano preparations of CBD for some children that are hard to dose. So I have, as a matter of fact, just before this webinar, I have a parent calling, for they need more CBD, what I call CBD active, which is a nano emulsion that makes the CBD more water soluble. But I think by not focusing strictly on CBD, but using CBD in combination with CBG, with CBDA, with THCA, eventually, for the most part, I think you find something that these kids and young adults will respond to. As a matter of fact, that patient was a 21-year-old. So, and that's the thing we see, the prevalence of autistic spectrum disorder is so great, and these kids are aging out and they're getting bigger and older, and these families need help. So yeah, there are no medications that address core symptoms. The social interaction, the poor expressive language, the expressive language deficits, and the OCD type, the repetitive behavior that makes life miserable for everybody. But at least there are no pharmaceuticals for those. But at least cannabis touches these neurotransmitter systems that contribute to these behaviors. Again, we don't have, and the pharmaceuticals that have been FDA approved for these other behaviors were by very slim margins. I mean, it was pretty, definitely not maybe a 20, for instance, with the antipsychotics, with the dopamine blockers, it was maybe a 20% improvement, which is really kind of a low bar, a very low bar, but it just shows that they're so desperate to do something that, okay, well, let's give them this. The medications that are used for the ADHD associated with autism generally don't work. And a lot of them are not anxiolytic, but anxiety provoking. So you have a kid who's already highly anxious, and then you give them a psychostimulant. It doesn't always make for symptom improvement. So that's, so to answer your question, I don't think it changes much. I don't do hormonal therapy, but trying to address the underlying comorbid conditions like anxiety and OCD and irritability. I use a combination of different cannabinoids.
All right, thank you. And we'll transition to epilepsy, where my understanding is that seizure disorders are not uncommon, or are more common with children in the ASD. And Dr. Russo, will go there with you, and if you would give some insight into that, and start there.
Right. Well, again, autism is a byproduct of some other neurologic conditions. So there are any number of brain insults, whether genetic, birth, after infection, that could lead to autistic features, but also produce damage to the brain that produces epilepsy. So there is this overlap. But epilepsy under any conditions is common. 1 in 200 people has epilepsy at any given time, and 5% of people will have a seizure sometime during their life. So we're talking about something that's relatively common to begin with. Maybe we'll call it a happy accident that we can treat different aspects of these disorders with the same medicine. And at this point, we should emphasize that while CBD has got all the attention as an anticonvulsant, it is not the only component of cannabis that has this attribute. THC is also an excellent anticonvulsant. It hasn't gotten the attention because of all the, I'll call it hysteria attached to its use, particularly in children. But in someone who's severely affected, there's no doubt in my mind that the cost-benefit ratio is in favor of using it. And then other components are also anticonvulsant. tetrahydrocannabivarin is. THCA seems to be, even though customarily it's felt it doesn't cross the blood-brain barrier, but that blood-brain barrier is impaired in severe epilepsy, and so it explains how it could get in and do its work. And then finally, among the terpenoids, linalool is strongly anticonvulsant, and our colleague Dustin Sulak relates a story of someone who had not been controlled on other cannabis preparations, came up with something new, and when it was analyzed, the only real difference was the content of linalool in the new preparation. And that's very potent. A small amount could make the difference between lack of control and gaining control. Jackie, you're muted.
Thank you. Yeah, and then that leads into your research that led to Epidiolex. And so treating a child with Epidiolex versus treating a child with artisanal CBD.
Yeah, a bit of a sore point here for me. Epidiolex was not the preparation I would have wanted. It is an isolate, essentially 97% pure CBD, and it's been well established. There was a meta-analysis study done for Barcelona showing that if we clinical studies of CBD isolate, pure CBD, the average dose in these severe epilepsy syndromes was about 27 milligrams per kilogram per day. Whereas in other studies, not all randomized controlled trials, I will admit, but in those studies with CBD as an extract, the equivalent doses necessary to gain control were more in the range of 6 milligrams per kilogram per day. Also, in the extracts, these lower doses were also associated with a much better side effect profile and a lack of the drug-drug interactions that are commonly seen with extremely high-dose CBD. So, you know, if the question were, do I think that there are better preparations to come with multiple cannabis components, my answer is absolutely yes.
And if you would repeat that study, is that your internet went out for a moment when you were saying, I read that study, but if you would share.
Yes, by Fabrizio Pamplona.
Right. Okay.
L-O-N-A.
All right. Thank you. Dr. Goldstein, with your patient population and those kids that do have epilepsy, any particular chemovars that you're finding that you use to treat your patients?
Well, I always look for preparations, and for the most part, unless the child is on a multitude of drugs that I'm concerned about drug interactions like valproic acid or clobazam, in general, I usually will start with a high ratio CBD and dose by CBD, and in children who are still growing or have not reached 50 kilos. In general, we'll go based, we do treat based on weight. And it's very important to understand that if you find a dose that works, you have to remember a number of the patients I've had, the only time they've ever had a breakthrough seizure was they outgrew the dose. And we always have to stay on top of that, make sure that patients are keeping up with the weight and not outgrowing the dose. But in general, for the preparations, the reality is that there's a multitude of criteria. One, they have to be reliable, meaning the patients can find it and it's the same every time. Mm-hmm. Two, it has to be affordable. Right now, there are companies that are selling CBD at around 2 cents per milligram. And there are some companies that are selling CBD at 35 cents a milligram. Now, if you only need 10 milligrams, it may not matter. But if you're on 600 milligrams, right now I have the patient with the highest dose right now is on 1,500 milligrams with almost full seizure freedom, with the occasional breakthrough. But he had multitudes of seizures every day. So it's a significant improvement in the quality of his life. And in fact, he went 3.5 years without seizures before he hit puberty. With with that very high dosing, it has to be affordable. I mean, you have to be able to sustain. So oftentimes, unfortunately, the cost of a product does play into what patients are using. I find that in California, where cannabis is highly taxed through the state licensed dispensaries, most patients are not buying their high CBD, low THC preparations through that. They're usually getting them from a kind of over-the-counter or online. And the key point there is you must have access to what we call a certificate of analysis, which is the testing result. Every batch should have a test. Many of these companies are being accused of being loosey-goosey and not being the same, but there are a number of companies out there who do realize that pediatric and maybe even adult patients with very severe illnesses are using their products, so they are trying to maintain consistency bottle to bottle. And now that I've been doing this for a long time, I have seen those companies that maintain consistency. And it can create a real problem if you decide to switch up your product in the middle. You know, it's not the same. Parents expect it to be the same because it's not medicine if you can't rely on it month to month and if you can't afford it. So all of these concerns apply. I would like to make a comment about Epidiolex. There are some of my patients who have switched over because of the financial burden, and a few have gotten good results and some have not. But I think that what's really important is that everything should be on the table for these families who often are at the end of the line in terms of their options. Now they're starting to get into, irreversible brain surgery, implantation of vagal nerve stimulator, all things that are quite intrusive and invasive. And so it's important that families understand there is not one product out there that we can rely on. There's a handful of things, and you may have to try a few different products before you find what works.
Yeah, thank you. And I'm watching the time. So real quickly, Dr. Fry, if this can be, I know it's a complex question, but with your patient population and your experience with Epidiolex versus truly plant-based, the artisanal.
Well, well, before Epidiolex was approved, I did get a number of patients referred from a local children's hospital, and started them on artisanal CBD. Once Epidiolex was approved, so a lot of them switched over to Epidiolex because of the cost. I did have some come back because they just got better results with lower doses of the artisanal, and some who didn't meet the specific criteria for Epidiolex for insurance purposes, which would be Lennox-Gastaut, Dravet, and now tuberous sclerosis. So a lot of them stayed with it. But I did have some who bounced back from Epidiolex. I've also found that I have one patient, I have a couple of patients, one who didn't respond to CBD, but has done wonderfully with THCA, and he's been on THCA for about 3 years now. We have to make it because we can't get it in the dispensaries. And then I have another one who did very well with a CBD product that I get that is CBD and CBDA. And this particular oil always had about 4% CBDA. And he got more oil, started having some seizures, and so got it tested, and sure enough, the CBDA had dropped down to about 2%. So we have to supplement. So we've added CBDA back into the oil, and he's back to being seizure free. So yes, it would be really great to have consistency in these oils, to be able to know exactly what's in them, have them stay the same, because once we find these ratios of cannabinoids or cannabinoids and terpenes, it's nice to be able to go back to them.
Thank you. I'm going to pass over the last question, which was the future of cannabis science and research, and hopefully with the change in leadership of the country, that we will have some positive outcome moving forward in 2021. So wanted to get to our questions. And I think I'll ask each one of you as a question, can you define what a low dose and a high dose means within your framework? So Dr. Goldstein, we'll start there with you. If you would define a low dose versus a high dose.
So in my opinion, so for CBD, low dose is usually under 50 milligrams. Some people say 25 milligrams, but somewhere between 1 and 50 milligrams is considered a low dose. High doses are usually in the hundreds of milligrams for those patients. Remember, we don't absorb everything we take, so you don't really know what you're getting actually into your bloodstream and into your brain. So remember, these are just, kind of guesses as to what patients are actually getting. But when you're taking it, if you know that 50 milligrams helps your pain, then you at least have a target dose, right, that you can measure out. For THC, what I call low dose is anywhere between 1 up to 5 or up to 10 milligrams. Most people who are cannabis naive will probably feel THC somewhere around 3, 4, 5 milligrams. There are, again, everybody's different. There are people who need higher doses in order to feel it, and other people are extraordinarily sensitive. I have a patient right now who is using a 2.5 milligram mint that she cuts into 4 pieces. So divide 2.5 into 4 pieces. That's her dose. Anything more than that, she feels a little bit altered, and she does not want to feel altered. So for THC, I think it's a little bit easier, but be aware that one of the things that's very important is THC in terms of medicinal effects has a pretty narrow therapeutic range for most patients. And for CBD, it's a very wide therapeutic range. I've got patients at 10, 20 milligrams, and I've got other patients, as I've mentioned, at like 1,500 a day, 600 a day, 300 a day. So CBD has this really wide range, and sometimes that's prohibitive, and that's why I might recommend using THCA, CBDA. I have found with THCA and CBDA for most patients, they will get results if they're using something that they can measure, like a tincture, somewhere between 2 milligrams. I've seen benefits all the way up to 20, 30, 40 milligrams. I have 2 patients seizure-free on THCA. One patient is getting 60 milligrams a day, and the other patient is getting, he's a little bit bigger kid, he's getting like double that. And then for CBG, I usually anywhere between, 1 and, again, starting low, 2 milligrams upwards to, I'd say 20 to 40 milligrams. For most patients, we don't really go that much higher, although I have heard of a person who said that his Tourette syndrome, and this is like through one of these, conferences where you meet people, he reported to me that 50 milligrams twice a day, so 100 milligram dose of CBG in combination with very low dose inhalation basically eliminated his tics, which is quite interesting. So again, starting low and titrating up, there's no magic number for any specific condition. It really is truly individual.
Dr. Fry, do you have something to add to that? And then I also, with the experience in the Maryland market where I am, it's frustrating is that unfortunately the processors, there's no standardization in their delivery. The droppers are not. Some do a great job are titrating the droppers. Dr. Goldstein, you're shaking your head, yes. And
don't use the dropper. Use a syringe.
Use a syringe.
A syringe, a measurable syringe.
Okay.
Easily available online.
Pardon me?
They're available online. 1 milliliter needleless syringes.
Great. Thank you for that.
Syringes, yeah. Technically a drop is 0.04 milliliters, and so you can convert that into milliliters or to drops, but yes, there's not much consistency in the droppers. I agree. I think for most of my patients, I rarely have had anyone need more than 15, maybe 20 milligrams of THC, and those are usually very complex pain syndromes that tend to be kind of difficult to treat. I certainly don't use that or not needed to use that much in patients with seizures or with autism. So I would agree that it's always about starting with a small amount. I've seen patients do beautifully with microdosing, and other patients need a lot more. But again, when you get up into the higher doses, you can get into some of the adverse effects of both CBD and THC. And again, none of them are life-threatening. I find that with older female patients who have, and from what I've read, I certainly haven't done the study, that they have increased density of CB1 receptors in the brain. They can be very sensitive to THC. I've had some patients have, did have a patient who had a partial complex seizure from THC, and another patient with a dissociative psychiatric disorder who had an event from too much THC. So I tend to be a little bit careful with it and just increase it gradually. But you take as much as you need to get the benefit that you're looking for, the adequate symptom relief.
All right, great, thank you. Dr. Russo, I'll pose this one to you from Jacqueline Gray. Since cannabis treatment is individualized from person to person, could cannabis be used as a preventative treatment for Alzheimer's disease, or do we only treat the disease once we know its progression? So this goes back to the discussion that that you and I had. So yeah.
Sure. So, if there is indeed a neuroprotective effect to cannabis in Alzheimer's disease or any other neurodegenerative disease, it can have its best benefit by starting early. There are diagnostic tests now that can identify someone who is susceptible to the development of Alzheimer's disease long before they show the signs or symptoms. Under those conditions, if the question were, should somebody begin early on, I'd say, yeah, I think that's a fair bet, considering the alternative, doing nothing, is going to lead to an inevitably bad result. Again, what's the best dose? Probably something very low, but getting some of this on board, if it's going to have benefit, it does make sense to start early.
Yeah, and that I had my personal concern about with the genetic factor of it, and treating myself, being mindful of being at higher risk.
Sure.
Thank you. From Renee, when discussing medical cannabis with PD patients, Dr. Fry, I'll pose this one to you. My concern with smoking and tremors may be placing a patient at risk of fire if lit cannabis joint is dropped.
With pediatric patients?
No, I'm sorry, at Parkinson's disease.
With Parkinson's.
Yeah.
Well, generally those patients, they're vape pens, vape concentrates that are used that are very easy to use. It doesn't require anything that's going fire, or so they're very safe. They're easy to use, and usually they're at higher concentrations. So just maybe a puff might be even enough. So yeah, my Parkinson's patients, we've stuck with vapes, vape pens.
And I am muted. And this one is from Carl Wagner, that is in a non-legal state, with medical cannabis being a risky proposition and involves going to neighboring states. So, but recently discovered Delta 8 THC as an option for insomnia, and a legal loophole allows it to be sold and purchased. My question, though, is for a friend whose daughter has ASD, but who has recently taken remarkable strides through microdosing with Delta 9 THC. Her daughter saying words, speaking phrases she's never has before, and again, though in a prohibitive state, and sometimes the supply chain dries up. I want to suggest Delta 8 is a legal option, starting low and going slow. Thoughts? Dr. Russo, you're shaking your head no.
Well, if the question is it helping? The answer is obvious, it has. However, no one should suffer the illusion that this is legal just because it hasn't been pursued. Delta 8 is a close relative of Delta 9, and just like CBD is technically illegal on a federal level outside of Epidiolex, which is FDA approved. So if you ask the FDA or ask the DEA about the legality of any of these, they'll say that they're all Schedule 1. And the same applies to Delta 8. And just because nobody's gone after it yet doesn't mean that they can't or won't. Now, I hope that won't be the case under the new administration, but right now, people have to understand that if they're going to do this, there is legal jeopardy attached.
Yeah. Thank you for that. And Dr. Russo, you did where I skipped over because of time of considerations of what the future holds for us, as you just spoke to with the new administration. And you have a paper that you suggest that you've written.
Yeah, it's 3 years old, but I think it's still very much on point. It's called Cannabis Therapeutics and the Future of Neurology. It was in Frontiers in Integrative Neuroscience, Volume 12, 2018. Any of my writings, including this, are available at ethanrusso.org. And they're free. It's my personal website, so there are no copyright issues. And I think I've got copyright on that one anyway, so no issue.
Well, thank you. Great lead into that. And Dr. Fry, your book and resources that you recommend, and how can people reach you?
Well, my book you can get on Amazon, Barnes & Noble. Some bookstores carry it. I can be reached at pfry@tacomacare.com. I'm also on the board of the Society of Cannabis Clinicians, and we're about to launch our new educational modules. They'll be coming out soon. I have 2 authors here with me on the panel. So it's exciting. It's going to be a wonderful curriculum with good core basic science and a lot of clinical experience in addressing a lot of these problems that we see.
Yeah. And do you have another book in you?
I have another book in me. It's not, it hasn't quite leaked out, but it's coming.
All right, thank you, Dr. Goldstein. And you have your second book. And what's if you'd share what's the difference between your first book and your second book?
Well, it's about 80% rewritten and updated. So there is some overlap because the basic knowledge is the basic knowledge, the endocannabinoid system, understanding the plant. But the new book has really basically taken almost all the research. By the way, everybody keeps saying there's not enough research, and I disagree. There's a ton of research. I spent 4 months before COVID locked in my office reading the research and trying to dial it down to put it into digestible chapters. There's a ton of research. And the big question is, you have to remember with cannabis, it's very complex. If you study a synthetic cannabinoid, can you jump to artisanal products and say the same thing about them? So there's a lot of complexity here. So I rewrote the book to accommodate for all of this new research that came out just in the last 4 to 5 years. And luckily there has been, if you look at the curve of research, it is just climbing. There's a lot of people interested in this. So it's important to understand that this is constantly changing, and the amount of information coming out from the scientific community is very fast paced. And always before today, I went online and reread some things that just came out just recently, because it really is a fast pace. There's a tremendous amount of information. And so the book is called Cannabis is Medicine, and it's available as well, Amazon and Barnes & Noble as well.
All right. Well, I want to thank each of you, a tremendous thank you for your time building up to this and delivering your clinical experience and your research. And thank you again for joining us. Like to thank the attendees for joining us, and certainly our sponsors, Vireo Health, Wana Brands, and District Cannabis, and to everybody. The next clinical webinar that the discussion that I'll be moderating is women's health. And so far on that panel, we're going to be discussing women's health, mental health, specific to women, reproductive health, sexual health, And Dr. Paloma Layfelt will be on that panel as well, Dr. Janester Wilson King. And if you would follow Cannabis MD on Facebook, Instagram, it's cannabis.md, and certainly the website cannabismd.com, where you will find regular updates and then the video profiles that I've thoroughly enjoyed hosting these clinicians on. So thank you again for joining us, everybody. Have a good rest of your day.
Thank you.
Thank
Bye-bye.
you.